Welcome from the Music City Center, Nashville, Tennessee. We're here at the EMS World Expo, the largest EMS dedicated event in the world. This is EMS World Presents Stories from Expo. Your story continues here.
Hello, we're here at EMS World Expo in Nashville. This is the EMS Garage / EMS World podcast kind of mashup double team. I'm here with Gustavo Flores, who is speaking on the pre-hospital management of the sepsis patient. What's the elevator pitch?
So, as you all know, sepsis is the number one killer of patients in the ICU, and I would say that there is a disconnect between the magnitude of the problem and the awareness that many EMS providers have of likelihood that this patient will be dead in 12 hours, 18 hours from their initial first contact. And there is a renewed interest in timely management. There are some standards that have stirred a lot of controversy, but regardless of what the hospital standards mandate or not, our involvement with the septic patient at the pre-hospital level is a golden opportunity to think about sepsis on a patient that is has an altered mental status, is hypotensive, you have no idea why, has a vague chief complaint, and when further assessed, we can easily identify this as a potential organ failure patient and start giving fluids, activating the sepsis alert, and so on, and dramatically improve the chances that this patient will receive timely antibiotics and aggressive critical care, the right care right now.
So, do you have recommendations, or, I mean, there's SEERS protocol, and there's how far should we be getting lactate meters on the truck? I mean.
So that's a good question, and there's a little bit of history behind, the definitions that were last updated in 2016. The third definition of sepsis, updated in January 2016, came after 25 years since SEERS came out in 1991. So the reason SEERS in 91 was so important is it gave us a tangible recommendation, something we can chew on to work on the potentially septic patient. You have an infection and you have SEERS, you have sepsis. Now we know that SEERS isn't adequate to recognize that some patients are in organ failure, and that's where QSOFA comes into play. So QSOFA meaning a shortened version, a screening tool, if you want to call it that way, for patients who will develop organ failure. Now, the thing with organ failure is that not all patients who have a serious infection have organ failure. That doesn't mean that they don't need immediate care. So QSOFA tells us about the subset of patients that are very, very sick. It's not sensitive enough for the full spectrum. It's good enough for the patients that are really, really, really at the higher risk end of the spectrum. So I would say it's a whole gestalt of SEERS, end-tidal CO2, QSOFA, that gives you the whole perspective of what's going on with this patient. There's no single marker that says you have a septic patient. You have a clinical scenario that, when taken into consideration, you're looking at a patient who has a very high mortality, even higher than a STEMI, higher risk of death. Therefore, we need to make sure that we are looking at all those elements integrated, not just one of them isolated.
And would you say that kind of the recognition of sepsis as an acute and very high mortality condition, like a STEMI, right? Because everyone likes to treat their STEMIs.
Right.
If we can is it a culture? Not only just we need to get the protocols and the treatment of it, but also a culture to say, hey, this is that call that you want to make a difference on.
So let me give you a tangible example, or a clear example that we can all relate. We know anaphylaxis kills you, right? And anaphylaxis kills you not because of the allergic reaction itself. It's your body's reaction to that allergen that suddenly begins to kill you. So it's not the allergy, it's your body's reaction that kills you. So in this case, it's not the infection, it's your body's reaction to the infection that kills you. So sepsis is equivalent of an anaphylaxis for the infected patient. So people think about infection like a pneumonia and sepsis being the same thing. Well, the infection is triggering the body's reaction, but it's the body's reaction, the real medical emergency here, just like an allergy is not a medical emergency, anaphylaxis is, and it just because it's a severe allergy, it's because your body is killing you at the same time. So understanding the difference and understanding that just because you have an infection doesn't mean you have sepsis. You're screening for sepsis, and being aware of it is critical. I can perfectly understand somebody saying, I don't think this patient is septic because X, Y, Z. That would be great because they're thinking critically. They're saying, I don't think there is sepsis. We can argue whether that's right or wrong, but they're thinking about it. My greatest concern right now is that people are not thinking about sepsis at all. They might be thinking, well, abdominal pain, a little bit hypovolemic, maybe they're just dehydrated. Like, think sepsis.
Yeah, well, and it's easy to kind of write off a confused elderly patient in a nursing home as, oh, that's just their baseline, but they're probably not calling because they're normally confused.
And it's so common. Sepsis is so common when you look at patients that are high risk, the elderly as well as the very small infants, that it probably happens. We know it happens a lot. Now, we interact with patients that are at risk of or already developing organ failure far more common than we are aware of because we're not recognizing it. So again, it's a matter of, yes, this patient is at risk. We're not thinking about it enough. We need to start doing it. Obviously, this will increase the number of patients we're calling in as potentially septic, or meeting clear guidelines to initiate resuscitation. And it does happen a lot. So if you're not considering it on a regular basis to patients like that, they're always having altered mental status because of pre-existing conditions, but the caretaker might say, yeah, but today's different.
Yeah.
And for instance, elderly patients don't have a good immune system, so they're not likely to mount a very a very dramatic inflammatory response. So you might not even see a fever. You might not even see the typical classical SARS signs and symptoms, and they would still be having the same reaction to the infection.
And so I have another question, and that would be, you get services to recognize it, and you get it to be on the radar. How important is early treatment, even if you can only get like 200 mils of fluid? And I say that because you could find a metro service, or you might find a metro service that says, well, why do I need to start? I'll be in the hospital 2 to 5.
So it's called system of care.
Yeah.
So when you're looking at, the same thing happens for trauma, STEMI, stroke, sepsis. When you're looking at system of care, you're looking at not you as a provider, you got to look at the patient. So our metrics shouldn't be based on the individual provider, they should be based on patient and patient outcomes. So when we're looking at starting care, it may not necessarily include anything you have to do. It may be simply activating, because at any given time, a typical ER may have 10, 15 patients you could classify as critical. And that's not an excuse for not paying attention to patients that are critical, but at this given time, that is your patient. Your eyes and ears, all your 5 senses are in tune with this patient that is critical. So you don't want the patient to slip into a busy system and not being recognized as a critical patient when they actually were. So all you needed was a few eyes and ears looking at the patient and saying, this patient actually has sepsis, and we should bump the acuity of this patient. And when you have a system of care, then you recognize, well, this patient, this hospital A has a sepsis alert protocol, and we can activate them as opposed to hospital B or C. So that triggers a different response from your pre-hospital provider that potentially could save this patient's life.
Right. I mean, you're not going to take a STEMI patient to a hospital without a cath lab.
Exactly. So it's not about you doing the thrombolysis or you doing the, we can talk about cath lab activation, pre-hospital cath lab activation or not. Regardless, you're still looking at a system of care, and you're saying, what can I do for this patient? So I like one of the slides from the PHLS course that says, so what kind of shock this patient has? What's the definitive treatment? Where is it located? And what can or should I do from now till I get there? So once you understand this patient is septic, and this hospital has a great ICU program with a good sepsis alert protocol, and that these are the core elements, like starting to give 30 mL per kilo of fluid, starting to measure lactate, start to optimize organ perfusion. We can start doing those things in the time frame in which this is my only patient and all my attention is dedicated to this individual.
Perfect. Well, I appreciate you coming and talking to us. I look forward to seeing your presentation tomorrow. If somebody wanted to get a hold of you, ask questions, kind of, learn how they themselves, if they're a hospital administrator or otherwise, or EMS, do you have a work email that they could?
Yes, you can find me in social media. My handle is gflores911. Pretty much that covers Facebook, Twitter, LinkedIn. I also learned that the Sepsis Alliance has a partnership with the National Association of EMTs, and you're going to start hearing some other information from the Sepsis Alliance. You can log into sepsis.org and you can find more information about this, just like there is also information on the Surviving Sepsis campaign on survivingsepsis.org. There are a couple of resources out there that may be focused towards in-hospital providers, but when you look at a system of care, again, it's no longer about who you are, or what you do, it's about what this patient needs. If you can deliver that particular care, then you do it. If you cannot deliver that particular set of care, your job is to make sure somebody comes on board, or you take this patient to the place where they can start doing it as quickly as possible.
Great. Well, thank you so much. And if you have more questions about sepsis, you can certainly find him on social media or go to sepsis.org.
Sepsis.org, yeah.
And for more videos and information on EMS World content, stay around, click on links on this page. I'm Aaron Gutzman, and this is the EMS World podcast / EMS Garage podcast.